Thank you very much. As you can tell from my slides, nobody is funding me. This is a presentation of a document that was published last week that Jim Mulshine is the lead author on in Frontiers in Oncology. And as we heard earlier, we're on the verge of having millions of CT scans from low-dose CTs available. And the question is, who is going to own them? And the current trend is for them to be locked up and in some countries owned privately. And think of the TikTok model of the social web model of ownership of data, or are these going to be used for public health and research and beyond? So I think this group should have some opinions on which way forward for this. So we've heard the challenges, the workload, process inefficiencies coming with the scale of lung screening that we'd like to see, what to do about the big three, and the volumes needed to investigate findings or to test hypotheses, whether AI or not AI. And in the past, we've had conversations about inconsistent calibration of machines. So these are some of the challenges at this point in history in 2026. We have these challenges. We also have some interesting breakthroughs that point to a solution. There's, of course, the availability of data on a scale that's hard to imagine. We have, of course, the gold standard of I-ELCAP that's not going to be challenged anytime soon, which took 3 decades and is superbly curated. We have the emergence of techniques with AI, with cloud-based capabilities, distributed processing, and things like that will enable us to access and evaluate CT scans without changing their location, to do that on a distributed basis. There is important work in the public health arena and the ethics world that says health data doesn't belong to the institution, doesn't belong to the patient, it belongs to the public. And that's a principle that can open up access to data, but frankly, it's been around for decades in various kinds of surveillance programs throughout a number of countries. And finally, the value of the opportunistic findings. What's kind of interesting is I'm not a clinician, but as I look at the big three, those are old opportunities. They're diseases that we know a lot about and have studied for years, and the ways to treat them are well known and established, and the drugs are cheap. So there's other opportunities that we're not even talking about that could open up with sufficient supplies of data. So this is a chart from the publication. This is Central United States. We happen to call it the Midwest for odd reasons, but it's the state of Minnesota, and the example of how a central analytic library could operate on various regional centers through Minnesota, and that's could be the example, either region or national, for this kind of library to operate. Now, what's kind of interesting is you compare this approach and a library approach to what you see with a lot of AI companies. It's a struggle to get quality images for analysis, and it costs a lot of money because typically hospitals, well, especially in the United States, think their images are so precious, so they'll charge hundreds of dollars or more, thousands of dollars for access to them. So you see AI products being brought to market based on a few hundred, a few thousand cases. And this is a different kind of scale. Even a single state like Minnesota in the central United States could generate vastly higher, orders of magnitude higher numbers. So there's been a lot of progress in pieces of this. This may sound like blue sky, but the elements are beginning to come together for this kind of public library, or could call it a public utility. There's a number of organizations, of course, I-ELCAP is the premier, but there's OSIC, MIDRIC have been painstakingly gathering images for analysis and have the techniques for doing that and accessing them and demonstrating what you can do. The images from NLST, even though they're, at this point, 20 years old, some of them, other sources of images. These have been critically important, but they've all been narrowly research-focused, relatively small scale, tiny scale compared to what we're going to see with broad lung cancer screening. And there have been constant budget challenges with all of these organizations. So, but that's the foundation. There's other technical work that's been done by Kiba, by Acumetra, others on how you can use technology on a distributed basis and surveil the quality of images and the findings. And finally, on the data privacy issue, that's also been worked out. There's regional health information organizations, there's other kinds of public surveillance. That means data privacy shouldn't be an issue, and I mentioned some of the ethical work that was done at Stanford. Time, sorry. I'm gonna close now, but just contrast the private equity model that we have today, where once a product is launched, there's no incentive to update it or to change it or to share any of the data to competitors. And that's really, I think, this organization and people in this room should have something to say about what we're going to do with this kind of data going forward. Thank you very much.